Imagine the exact instant your perspective on something fundamental shifts forever. For me, that moment arrived through nothing more dramatic than a phone call from my 72-year-old mother. She was sitting in a quiet clinic waiting room, surrounded by the usual hum of fluorescent lights and murmured conversations when she dialed my number. Her tone was thoughtful, not alarmed, just the quiet voice of someone who has always trusted my judgment in medical matters. "Clarence," she began, "they're about to give me this vaccine here at the clinic, and before I say yes, I wanted to check with you first. What do you think?" When she told me the name of the vaccine, a cold wave washed over me. My response came instantly and instinctively. "Mom, listen carefully. Stand up right now, pick up your purse, and walk out of that office. Do not let them administer that shot under any circumstances." There was a long pause on her end. I could almost picture her brow furrowing in confusion. "But the nurse was very reassuring," she said softly. "She said it's strongly recommended for people my age, that it's the standard thing to do." I took a breath and replied with all the calm urgency I could muster. "Recommended is one thing, Mom. Safe and appropriate for you specifically is another entirely. Trust me on this. Please leave now." She did. And as I hung up, my hands were shaking. That single conversation hit me harder than almost any clinical case in my career. Here was my own mother, the woman who raised me, who supported every late-night study session that led me to become a doctor, nearly receiving a vaccine that carried genuine risks at her stage of life, simply because no one had paused to consider her age-related biology in a personalized way. If this could happen to the mother of a physician who knows the system inside out, how many other elderly loved ones are out there right now, sitting patiently in exam rooms or pharmacy chairs, sleeves rolled up, placing complete faith in whatever is handed to them without a single probing question? Before you decide this is heading in a predictable direction or click away, let me be absolutely upfront about my position so there's no misunderstanding. My name is Dr. Clarence Martin. I am not anti-vaccine. I want you to hear that loud and clear. I am not opposed to vaccination in general. My entire professional life has been built on the principles of preventive medicine. I've personally administered thousands of vaccines over the years. I've seen the profound, life-saving impact they have. Diseases like polio that once crippled children by the thousands are now virtually unknown in vaccinated populations. Measles outbreaks that used to fill hospital wards have become rare events. Tetanus, diphtheria, pertussis. These threats that terrified previous generations are now manageable thanks to immunization. Vaccines are, without exaggeration, one of the most powerful tools in the history of human health, responsible for adding decades to average life expectancy and sparing countless families unimaginable grief. Yet, precisely because I respect vaccines so deeply, I also insist on using them wisely. Medicine isn't dogma, it's nuance. Not every vaccine is equally suitable for every person at every age and health status. And when we cross into the territory of 60 and beyond, biology undergoes a fundamental transformation that demands we adjust our approach. This transformation is called immunosenescence, the age-related remodeling and gradual weakening of the immune system. It's not a disease, it's a normal part of aging. Here's what it looks like in practical terms. The thymus gland, which produces fresh T cells, the commanders of adaptive immunity, shrinks over time and produces fewer naive T cells. Existing T cells become less responsive and more prone to exhaustion. B cells produce antibodies, but those antibodies are often of lower affinity and quantity. Innate immunity, our first-line defenses like macrophages and natural killer cells, becomes dysregulated, leading to chronic low-grade inflammation, termed inflammaging, that paradoxically makes fighting new threats harder. Recovery from immune activation slows. All of this means that older adults are more vulnerable to infections and may respond less robustly to certain vaccines, or, in the case of live vaccines, face heightened risks from the attenuated pathogen itself. These aren't theoretical concerns. They're documented in immunology research, geriatric medicine textbooks, CDC advisories, and my own clinical experience over decades. Organs process medications and biological agents differently too. Kidneys filter more slowly, liver metabolism changes, comorbidities accumulate, diabetes, heart disease, autoimmune conditions, immunosuppressive drugs for arthritis or cancer. A vaccine profile that's perfectly fine at 35 or 45 can tip into problematic territory at 70 or 80. That's the foundation for what I'm sharing today. As a physician who has dedicated my career to caring for people across the lifespan, and as a son who would move mountains to protect my parents, here are 5 specific vaccines I would never allow my own mother or father to receive after the age of 60, unless an extraordinarily compelling, individualized reason emerged after exhaustive discussion with trusted specialists. These aren't obscure shots. Several are still commonly recommended or offered to seniors in everyday settings. I'll walk you through each one carefully, the science behind my concern, why the risk-benefit equation shifts with age, documented issues I've seen or read about in literature, and, most importantly, the safer, more effective modern alternatives that actually provide robust protection for aging bodies. If any part of this resonates, if you have aging parents, grandparents, or loved ones, please stay with me to the very end. Some of these will surprise you. And if you find this helpful, meaningful, or potentially life-protecting, I ask you from the heart, subscribe to stay connected for more honest conversations like this. Give it a like if it speaks to you, and share it widely. Text the link to your brothers and sisters. Post it on Facebook where aunts, uncles, and cousins will see it. Forward it directly to your mom or dad with a note saying, "This made me think of you. Let's talk." Moments of awareness like this have changed outcomes for families before. They can again. Let's begin with the vaccine that almost reached my mother's arm, the one I told her to flee from. Number 1. The live attenuated influenza vaccine, better known as FluMist, the nasal spray flu vaccine. This one remains surprisingly popular despite its limitations. People gravitate toward it because it's non-invasive. No needle prick, just a gentle mist sprayed into each nostril. In seconds, you're done. No pain, no tears, no anxiety about injections. For many, especially needle-phobic seniors, it feels like the ideal option. But here's the crucial fact that gets overlooked far too often. FluMist contains a live attenuated, weakened influenza virus. In a young, healthy adult with a fully competent immune system, this weakened virus replicates just enough in the nasal passages to stimulate a strong, broad immune response, mucosal antibodies, systemic antibodies, T-cell memory, all without causing illness. The body clears it efficiently. After age 50 or 60, however, that same controlled replication becomes unpredictable. The FDA has explicitly not approved FluMist for anyone 50 years or older, citing insufficient safety and efficacy data in that group. Yet in practice, whether due to oversight, miscommunication, or outdated protocols, I've heard countless stories from patients, colleagues, and online forums of seniors being offered or even receiving it without proper age screening. In the context of immunosenescence, introducing a replicating live virus into a slower, less precise immune environment is like tossing a lit match into dry grass during a slow-burning fire. It can smolder longer than expected. In my own practice and from peer reports, I've seen older patients develop unusually prolonged flu-like symptoms. Fatigue that lingers for weeks, persistent nasal congestion turning into sinus infections, low-grade fevers, or secondary respiratory complications like bronchitis. These weren't coincidences. They were avoidable adverse outcomes tied directly to the live nature of the vaccine in an aging host. Thankfully, we now have outstanding inactivated alternatives designed precisely for seniors. High-dose inactivated vaccines like Fluzone High Dose, containing 4 times the antigen of standard shots to compensate for weaker responses, and adjuvanted vaccines like Fluad, which includes an immune-boosting additive to provoke a stronger antibody and cellular response. Multiple large-scale studies and real-world data show these provide superior protection against flu infection, hospitalization, and death in people 65 and older compared to standard dose vaccines without any live virus risk whatsoever. My unequivocal advice: if a provider suggests the nasal spray for anyone over 60, decline politely and specifically request the high-dose or adjuvanted injectable version. That's the protocol I follow religiously for my parents every single flu season, and it's what I urge for yours. Number 2. The discontinued but once common shingles vaccine, Zostavax. If your parent or grandparent received a shingles vaccine sometime before 2020, it's very possible they got Zostavax. For nearly 15 years, it was the primary, and for a long time the only shingles vaccine available. It used a live attenuated strain of the varicella zoster virus, the same virus behind childhood chickenpox, which lies dormant in nerve roots and can reactivate later as shingles. Physicians prescribed it widely because even partial protection seemed better than none against a disease notorious for causing intense, burning pain. But accumulating data revealed major shortcomings in older adults. Efficacy declined steeply with age. Clinical trials showed around 51% effectiveness in the 60-69 range, dropping to roughly 18 to 20% in those 80 and older, barely better than placebo for the oldest groups. More concerning, because it was live, it posed the same replication risks in immunocompromised or immunosenescent individuals. Reports documented cases of vaccine strain virus causing actual zoster-like rashes, disseminated infections, or prolonged symptoms, particularly in people on steroids, chemotherapy, biologics, or with diabetes cancer. Recognizing these limitations, manufacturers and health authorities discontinued Zostavax in the United States and many other countries around 2020. The replacement, Shingrix, represents one of the most impressive vaccine advancements in recent decades. It's a recombinant subunit vaccine, just a viral protein plus a potent adjuvant. No live virus at all. Large pivotal trials demonstrated 90–97% efficacy against shingles and post-herpetic neuralgia across all age strata, including those over 70 and 80, with protection holding strong for at least a decade so far. Side effects are mostly local, arm soreness, or transient flu-like symptoms, but the safety profile is excellent even in frail elders. If your loved ones haven't received shingles protection yet, prioritize getting Shingrix, 2 doses, 2 to 6 months apart. If they had Zostavax previously, speak with their doctor about completing the series with Shingrix. The earlier immunity has very likely waned substantially. Shingles is far more than a temporary rash. In seniors, it frequently leads to post-herpetic neuralgia, debilitating nerve pain lasting months to years, ocular involvement risking permanent vision impairment, increased stroke risk, profound fatigue, depression, and reduced independence. Preventing it matters enormously. Number 3. The yellow fever vaccine. This one doesn't apply to everyone's daily life, but it's becoming more relevant as active retirement travel explodes. Millions of baby boomers and older adults are crossing off bucket list destinations, safaris in Kenya, Amazon cruises in Brazil, cultural journeys through parts of sub-Saharan Africa or Southeast Asia, where yellow fever vaccination is often a strict entry requirement or strong recommendation to prevent a potentially fatal mosquito-borne illness. The yellow fever vaccine itself is remarkably effective against wild virus, near lifelong immunity in most recipients, but it's a live attenuated vaccine, and it carries one of the highest documented age-related risk profiles among currently used vaccines. CDC surveillance and post-marketing studies have repeatedly shown that adults over 60 experience a substantially elevated incidence of serious adverse events compared to younger groups. The most severe is yellow fever vaccine-associated viscerotropic disease. The attenuated virus replicates systemically and attacks multiple organs: liver failure, renal dysfunction, hemorrhage, multi-organ collapse, with case fatality rates approaching 60% among those who develop it. While these events remain rare overall, on the order of a few per 100,000 doses, the relative risk increases markedly with each decade past 60 and skyrockets further in the presence of comorbidities like thymic dysfunction, autoimmune disease, or medications that alter immunity, common in seniors. My personal stance as both doctor and son: if the travel is non-essential or flexible, reconsider the itinerary or seek a medical waiver. Many countries accept documented contraindications. If the trip is truly once in a lifetime and unavoidable, engage in an honest, detailed risk-benefit discussion with an experienced travel medicine or infectious disease specialist well in advance. Sometimes the disease risk in the destination outweighs the vaccine risk, other times it doesn't. But I would never lightly expose my own father to a known, age-elevated chance of a potentially fatal complication for the sake of a vacation. Number 4. The oral typhoid vaccine, Vivotif capsules. Another travel-related one. This arises when seniors plan extended stays in regions with poor sanitation and high typhoid fever prevalence. Much of South Asia, India, Pakistan, Bangladesh, parts of Africa, Southeast Asia, or Latin America. 2 typhoid vaccines exist: the injectable Vi polysaccharide, inactivated, and the oral live attenuated Salmonella typhi capsules, Vivotif. By now the pattern is clear. Live attenuated agents require extra scrutiny in older adults. Vivotif involves swallowing capsules that release live bacteria in the gut, where they replicate briefly to stimulate immunity. In younger people, this usually causes only mild GI upset, if anything. In seniors, however, side effects can be more pronounced: nausea, diarrhea, abdominal pain that lingers, and the vaccine can interact unpredictably with common medications, antibiotics, proton pump inhibitors, antacids. Efficacy data in those over 65 is limited, and the live nature raises theoretical concerns about prolonged shedding or dissemination in weakened hosts. The injectable version sidesteps all of that. No live organism, no GI replication, simpler safety profile. For any senior needing typhoid protection, I always recommend switching to the shot. More broadly, travel vaccine consultations for older adults should never be cookie-cutter. Insist on a thorough review. What is the exact itinerary, duration, accommodations, health status, medications, true exposure likelihood? Personalized decisions save trouble. Number 5. The BCG vaccine, Bacillus Calmette-Guerin, for tuberculosis. In the United States and most Western countries, BCG isn't part of routine adult immunization. It's primarily given to infants in high TB burden nations, but certain scenarios bring it into play for seniors, prolonged humanitarian work, or residents in high TB areas, occupational exposure, healthcare workers in endemic settings, or specific therapeutic uses. Intravesical BCG instilled into the bladder for non-muscle invasive bladder cancer treatment. Emerging research has even explored off-label immune-modulating effects of BCG in aging or autoimmune contexts. BCG is a live attenuated strain of Mycobacterium bovis. In healthy young people, local reactions, ulcer at injection site, are the main issue. In older adults, particularly those with any degree of immune compromise from age, diabetes, steroids, or cancer, it carries a real risk of disseminated BCG infection. The bacteria spread beyond the injection site, causing fever, night sweats, weight loss, lymphadenopathy, osteomyelitis, or multi-organ involvement. Treatment requires prolonged multi-drug anti-TB regimens, which themselves pose hepatotoxicity, nephrotoxicity, and other burdens on aging physiology. In virtually every conceivable situation, I'd advise my parents against BCG after 60. Safer TB prevention strategies exist: targeted testing and isoniazid or rifampin prophylaxis for latent infection, rigorous exposure reduction, masks, ventilation, avoiding crowds in high-risk areas, and vigilant monitoring. Live bacteria introduction simply isn't worth the gamble. Now let's pull back and address the bigger picture. Because this conversation exists in a noisy, polarized landscape. On one extreme are voices claiming every vaccine is inherently toxic and should be avoided entirely. On the other are those insisting all vaccines are flawless, risk-free, and unquestionable for everyone regardless of context. Both extremes distort reality and do a disservice to public health. The truth, as it so often does, resides in the thoughtful middle ground. Vaccines represent one of modern medicine's crowning achievements. Full stop. They prevent suffering on a massive scale. But like any powerful intervention, surgery, antibiotics, chemotherapy, they must be applied with precision, individualization, and respect for the patient's unique physiology. Aging changes everything about immunity, pharmacokinetics, and risk tolerance. What delivers optimal benefit at 30 may require modification or avoidance at 70. My deepest motivation here is personal. My parents sacrificed endlessly, long hours, financial strain, emotional energy, so I could pursue this path and become the doctor I am. Every medical decision involving them is filtered through that lens. What would give them the longest, healthiest, most independent years possible? What would I accept for myself in their position? I extend that same care to every patient who sits across from me, and that's why I created this message for you. If watching this stirs any guilt, perhaps because a loved one already received one of these vaccines, please release it. Medical knowledge evolves rapidly. Decisions made 5, 10, or 15 years ago used the best information available then. The fact that you're here absorbing this means you're actively caring, learning, and advocating. That's powerful. Going forward, I'm not asking you to reject vaccines wholesale or distrust healthcare providers. Quite the opposite. Be an engaged partner in care. Go to appointments with your parents when possible. Ask respectful but direct questions. Is this vaccine live or inactivated, recombinant? What are the specific risks and benefits for someone in their 70s, 80s with their conditions? Are there age-optimized alternatives? How does this fit their overall health picture? These are the hallmarks of good medicine. Providers who value informed consent will welcome them. Those who bristle or dismiss may not be the right fit. And to be completely clear about what I do enthusiastically recommend for adults over 60, annual high-dose or adjuvanted influenza vaccines, flu remains a leading killer of seniors. Tens of thousands die yearly in the U.S. alone from flu complications. Shingrix for shingles, game-changing efficacy. Pneumococcal vaccines, PCV20, or appropriate combinations to prevent pneumonia and invasive disease. Updated COVID-19 boosters for those at continued risk. TDAP boosters every 10 years, or as indicated, for tetanus, diphtheria, and pertussis protection. These use inactivated, subunit, or recombinant technologies, have extensive safety and effectiveness data in older populations, and target diseases that disproportionately hospitalize and kill seniors. This isn't about fear. It's about empowerment through accurate information so you can protect the people you love most. If this video has given you pause, clarity, or a reason to pick up the phone and talk to family or a doctor, I consider that a success. Please take a moment right now. Like if it moved you, subscribe so we can keep having these real conversations, and share it generously on social media, in family group chats, via text. Information like this travels best person to person. Thank you sincerely for giving me your time and trust today. I'm Dr. Clarence Martin, speaking to you as one caregiver to another. Take good care of yourselves, and above all, take tender care of the elders who once took care of you. They may never say it aloud, but they count on your voice in the room. Until we speak again, stay well, stay curious, stay loving.